All right, guys, moving on to chapter 20, elbow and forearm. Taking a bit of a risk here. I'm actually recording at home, so we'll see if I make it through the whole thing without my internet going out. Okay, moving on to objectives. I promise, I always test this out. There we go. Okay, so general rehab considerations. So talking about the joint stresses, we went over this in the shoulder as well. A baseball pitcher, there are 2,300 degrees per second of joint stress of force. In the javelin, there's 1,900 degrees per second. Like that's huge. The greatest force on the elbow is in the late cocking phase or in the early acceleration or deceleration phases. In the acceleration phase, we have compressive forces laterally and distraction forces medially. Repeated or excessive tension stress injuries includes neuritis, tendinopathies, medial joint sprains, and muscle strains. Repeated compression injuries include osteochondritis dissecans, bony osteophytes, loose body formation, articular damage, and degeneration. Okay, so again, tension stresses and compressive injuries. A flexion contracture is pretty common in athletes who have a lengthy throwing career. And a lot of times, if I see patients that have had previously had an elbow injury or even an upper arm injury, like a fracture of the humerus, they very commonly have flexion contractures. So just know that the elbow range of motion is something that we need to get back after an injury. So this is just going over some of the joint stresses in the different sports. So tennis, there's stress on the lateral epicondyle during the backhand stroke, the medial epicondyle distraction stress during overhead serves, and when they hit the forearms late. Gymnastic, as you think about the compressive force on the elbow, it's a little more on the lateral side due to the natural valgus position of the elbow. So if you think about when your arms are at the side and that carrying angle, if you translate that to an overhead motion and weight bearing, we have a little bit more force on the valgus aspect of the elbow. In golfers, they can have medial distraction on the trailing elbow and compression on the leading elbow. So it's a very unique structure. There's a high degree of congruency due to the bony anatomy, all that stuff. It's a very stable joint. The athenerosis helps in stabilizing the medial forearm muscles. After an injury or surgery, the capsule thickens though, and it has a high number of myofibroblasts that leads to capsule stiffness and contracture, just like we were talking about. The anterior capsule is very thin, so if you have an injury and you have thickening, like that's not what that joint is used to. With every elbow injury, you'll see as we move on, early mobilization is encouraged. More than 2 weeks of immobilization can cause elbow mobility restrictions, and adhesions can occur easily in this joint. The anterior joint capsule, sorry, I just said that, is normally thin and easily damaged if it's stressed too aggressively. So when we want to have that early mobilization, we don't very commonly have high intensity stretching or high intensity passive range of motion. Passive overstretching can cause soft tissue tearing, scarring, and loss of motion, loss of joint motion. Early stretching is primarily active, not passive, almost always pain-free, as the next line says there. So we're not doing aggressive stretching or aggressive passive range of motion early on in the elbow. The joint mobility, it's made up of three different joints: the humeral ulnar, the humeral radial, and the radial ulnar joint. The resting position for the humeral ulnar is 70 degrees of flexion and 10 degrees of supination, closed practice full extension. So we're obviously not going to mob that joint in a full extension position. We're going to start it in that resting position, and then we're going to move through different positions if needed, but in general, we're going to mob in this range right here. Humeral radial joint, resting position is full extension and full supination, and closed practice mid-flexion and mid-pronation. Radial ulnar, resting position, 70 degrees flexion, 35 degrees supination, closed pack, full pronation, or full supination. Okay, again, we want to go open pack to begin mobs. Closed pack you can use to provide stability in an exercise if you need to, if a certain joint has been injured and you are just starting weight bearing activities, for example, or maybe weight bearing is the best one I can think of. You might want to start them out in a closed pack position to get that stability. With the force application, remember that when lifting weights with the elbow extended, it places more stress on the anterior elbow. And when your elbow is flexed, it has more stress on the posterior elbow. The resultant force is up to 3 times the body weight when the elbow is flexed to 30 degrees. Okay, the resultant force is up to 3 times the body weight when the elbow is flexed to 30 degrees. So with rehab techniques, first off, we're always going to start with those pain modalities, things to lessen that pain. Then we're going to move on to our manuals, our trigger point release, and our soft tissue mobs. Cross friction can be done over the lateral and medial epicondyle for treatment of the tendinopathy. I do cross friction. And one thing the book doesn't mention is an ice massage. I use an ice massage a lot for tendinopathies, as opposed to just a bag of ice. Then the table below just lists common trigger points. Joint immobilization, remember the capsular pattern for the elbow is flexion is more limited than extension, supination, and pronation are equally limited. This is where our joint mobs come into. When we perform our joint mobs is when we have that capsular pattern. So there's pictures in your book, excuse me, of all of these. This is humeral ulnar joint. This is distraction. So you can see she has a nice flex. She's sitting on a chair. I usually do this in sitting, and I have this part is resting up on her shoulder here, and that's providing some of that counter force. I wish her hand was even a little bit more snug to the joint line there. Yeah, maybe it is, and just the picture's deceiving. But you want to make sure to stabilize the humerus, otherwise you're just going to get shoulder distraction as well. So you want to try and stabilize the humerus, then you want to sink down and take up the slack, and you are distracting that joint. It's used to relieve pain and increase range of motion. So on the medial glide, I don't know that I've ever used this one. Again, I'm not saying it's wrong, I don't ever use it. To be honest, I don't treat elbows and hands very much anymore because we have an occupational therapist who comes down to our clinic 2 times a week, so she gets most of the elbows and hands. But sometimes, ironically enough, they did not learn how to mob the elbows, so we've had to show her some of the elbow mobs. This is the one my coworker and I prefer as the distraction. But anyways, the medial glide, so again, she's right on that joint line. She's just going to provide that little bit of medial force. But then you're just going to switch the hands to get the lateral glide. Both of these are used to relieve pain and improve elbow flexion or extension range of motion. Then moving to the humeral radial joint, this is how you do distraction. Notice that it's just not a straight pull down, that we have just a little bit of a medial force as well, because we're distracting that humeral radial joint, because remember it's more over here. So again, just trying to open up that space. We're going to use that to reduce pain and improve elbow extension. The anterior glide, again on the humeral radial joint, is to decrease pain, increase flexion, and the posterior glide is going to be to increase extension. So again, this is kind of showing you both of them there. So if you are going down, you are doing that posterior glide. Obviously, if you're pulling up, you're doing the anterior glide, okay? Again, anterior for flexion, posterior for extension. With the radial ulnar joint, the dorsal glide, again, is used to reduce pain and improve pronation, which makes sense. So again, you're just moving at a posterior glide there. And again, pictures kind of be deceiving. I get a little bit more of my palm on there as well. It looks like she's kind of digging them with her thumb. She might not be. Again, pictures can be deceiving just because it makes it a little bit more comfortable if that force is spread out a little bit more. Okay, then a ventral glide. Yeah, because there again, she's got more of her hand on there. And notice how they are doing it in kind of the midpoint of pronation and supination. It's going to be used to reduce pain and improve supination. And again, her force is coming just like the arrow shows you there. Okay, flexibility exercises. Some people use the CPM for the elbow. Early mobilization there again. And then they also mentioned progressive static splinting. And there is some difficulty deciding between letting the elbow heal and preventing the stiffness and loss of motion. That's definitely an area that we could use more research in because it's very up for debate because you don't want the adhesions to occur, but at the same point, you need it to have the time for the healing. Prolonged stretches must be applied with caution, only used when the active stretches have not been successful. So like with a post-op knee, for example, a post-op total knee, I am okay with providing a prolonged sustained stretch, like right off the bat as pain tolerates, if we really need to get that extension range of motion. That is not the case with the elbow. With the elbow, you always want to try the active first. Then you're going to use the prolonged stretches a little bit later in rehab when the active stretches have not been successful. They do use progressive splinting. Again, it's a prolonged low-level force for connective tissue lengthening. There's 3 techniques used: static progressive, dynamic progressive, and serial casting. Serial casting is not used very often because of the cost of having to go in frequently. Serial casting I do see used in little kiddos. I have a little kiddo he did have serial casting for his legs. But the static progressive and the dynamic progressive splinting are the most commonly used techniques. When you are doing prolonged stretches with the equipment, then again, they're including this equipment, you use less force than you think is needed as you want a longer duration stretch. So you want to be able to maintain it. So this, they're putting the weight up here to stabilize the shoulder, and they want no more than 4 pounds of force to stretch to increase flexion range of motion. Okay, so again, it's just a nice little setup, or supported on the posterior aspect of the upper arm here. Again, weight to stabilize the shoulder and just applying that force down there. We don't want it to be aggressive because, again, remember, the anterior capsule does not do well to aggressive stretching. You can use an isokinetic machine if you have it available to set at a desired range, and then they just maintain that range. Again, I'm not super familiar with that, so I can't give you much more than just what the book said there. This would be an example of a prolonged stretch for the supinators. You want to maintain for 5 minutes if the patient is able to tolerate. Again, when they're doing this one, you want to watch for the compensations up at the shoulder, or you might even get some lean here in the trunk when you are stretching into supination. Okay, active stretches don't require a great deal of equipment. They're easy to perform and can be done throughout the day. You can see them on page 747 to 449, man. 747 to 749 there in your book. Again, they were super simplistic, so I didn't feel like we needed to go over them. When we move on to strengthening exercises, as always, you're going to start with your isometrics, move to isotonics in the straight plane, progressive diagonal plane, plyometrics, functional exercises, performance, and then sport-specific exercises, or performance-specific exercises, sorry. Isometrics are going to hold for the 6 seconds, repeat 10 reps, avoid maximal contraction. Flexion, if performed in supination, pronation, and neutral on different angles of elbow flexion, just to get the difference in the brachialis, the brachioradialis, and the biceps brachii. Okay, the extension is also performed in different ranges of motion in that extension range of motion, just to make sure that we're stretching that triceps in the different ranges. Manual resistance exercises, you want to make sure you're moving through the full range when you apply these. Movement should be nice and smooth. If you have a point in the motion where they're a little bit weaker, you can have an isometric hold. Just let them know that that's going to happen, and that way you can strengthen right in that range that's a little weaker. Elbow flexion and extension to resist them, to bias, not necessarily. So remember, this is on to bias. So to bias the biceps, we're going to have the forearm in a supinated position. To bias the brachialis, you're going to have it in a pronated position. And to bias the brachioradialis, you're going to have the forearm in a neutral position. From supination and pronation is the elbow flex to 90 degrees. Okay, she does it like this. I typically do it in sitting. Again, this is not wrong by any means. I'm just telling you how I do it. I do it in sitting, and I go with a handshake. I know that definitely gets lower radial ulnar joint as well, but that's just how I feel like I can get the best resistance. Is just going with a handshake range of motion and moving them through that pronation and supination. Obviously, if there was something more distal going on, that would not be my method of choice. I would do something more like this, but I just generally test it with a handshake as well. Straight pain resistant exercises, the elbow doesn't do too much, which is good. It flexes, we're working the biceps, all the elbow flexors, extensors, mainly the triceps, and then the supinators and the pronators, okay? There's a lot of overlap from the shoulder in regards to the exercises for plyos functional performance specific. And that's why we're kind of doing all upper extremity together, because there is so much carryover. So we're not going to to continue to beat this down. We're just going to say, hey, remember your shoulder exercises that do this. Specific goals in rehab, you guys know this, we're just reviewing again. Phase 1, passive phase, decrease pain, relieve signs and symptoms, prevent deconditioning of unaffected segments. Phase 2, the active phase, regain normal range of motion, easy strengthening, and proprioceptive exercises. Phase 3, resistive phase, we're going to do normal proprioception and strength, and the aggressive phase is your functional and sport specific. Moving on to specific conditions, epicondylopathy, there we go. AKA epicondylolgia. You got it. We need to correct the cause of the injury with any of the epicondyle issues. Okay, we have to correct the cause of the injury. Lateral epicondylopathy. you know, I just know it as lateral epicondylitis. I know it's not an itis because it's not an inflammatory process, but I'm just going to refer to it as that. Know that it's epicondylopathy. It's also known as tennis elbow. This is more common. Tennis elbow is more common than the golfer's elbow. It commonly involves the extensor carpi radialis brevis. You know, that's the one where if they lift that middle finger, resisted middle finger extension is painful for lateral epicondylitis. Medial epicondylopathy, golfer's elbow, deals with the flexor tendon mass, specifically the flexor carpi radialis and the pronator teres. Signs and symptoms are going to have the gradual onset of pain. Initially, it'll only start with pain after activity. Then it goes to pain at the start of activity that improves, then returns to pain once the activity is stopped, to eventually becoming painful more consistently. Grasping and handshakes are going to be painful. They'll have pain with the chairlift test if it's the lateral epicondylitis, or again with that resisted middle finger extension. The pain will be very localized either to the lateral or medial aspect, depending on which is involved. They'll have decreased grip strength, and wrist flexion and extension strength will be decreased due to pain. Conservative rehab, which is done most of the time, is you have to correct the cause of the injury. Is it something that has to do with the fit of the hand implement used? You know, is the racket not the correct size? Is it not the correct tense? What's the word I'm looking for? Is it strung too tight? I don't know what the correct terminology is for that one. So in phase one, we're going to ice. We're going to use ultrasound. You know my thoughts on ultrasound. Again, if it's a little kid, you have to be cautious with ultrasound because if you think where the epicondyles are, you know, there's a growth plate there. So just be cautious with that. Cross-section massage is used very often. Shock wave therapy, manual therapy. They might use the tennis elbow strap, and you also want to do flexibility and pain-free range. So you definitely want to make sure that you get those wrist flexors and extensors stretched, because that's generally what is causing the discomfort. The tennis elbow strap, you know, if it's something that allows them to get through a game, more power to them, as long as the pain is not worsening when we come out of the strap. Always have mixed thoughts on braces. We're going to avoid aggressive range of motion, again, because we don't want the capsule thickening, and stretching exercises early in the rehab. Again, aggressive is the key word there. We can have the range of motion and stretching exercises, but they're not going to be aggressive in the early rehab. Joint lobes, if it's capsular pattern infield and the resistive phase, can be added. We're going to do an eccentric strengthening program because, again, it's a tendon issue as well. It just happens to attach to the epicondyle and it's pulling on the epicondyle, and that's why we're having the pain, but we have to strengthen that tendon. The trunk and shoulder exercises should be introduced if possible. There's weak evidence for use of isokinetics in the use of epicondylopathy. Again, they don't say don't use it, but there's not tons of evidence to support its use. So with conservative rehab, this is a counterforce brace. This is what it's showing you. To be honest, I'm not super confident on what the difference in that one is versus the tennis elbow strap. So I'm not sure there of what the difference, because it looks awfully similar other than the fact that it's just a little bit wider. But the goal of this one is just going to reduce the wrist extensor activity. So kind of what it does is it kind of holds this down, or at least I'm assuming, because again, I'm not sure with this brace, but I know with the tennis elbow brace, the reason it is more is because it kind of tacks this down here, for lack of better words. So then we're not getting so much pull in the lateral epicondyle because it is helping to support this insertion inside here, okay? So again, the muscles are still pulling and everything, but this has just helped to stabilize up here. We need to examine equipment for appropriateness, racket weight, the stiffness, and the size. Post-surgical rehab. Luckily, with most of these, it responds well to conservative treatment. Again, I use an ice massage as well, sorry. If it is surgery, the pathological tissue is removed. They have a similar progression to the conservative treatment, except the initial 2 weeks include post-op concerns, you know, because there still would be in that inflammatory phase there for a little bit longer. They might be in an elbow immobilizer, locked at 90 degrees of flexion, 2 days, then is needed for pain. The counterforce base may be used until they have sufficient strength to be able to maintain that area without pain. We need to make sure that we include active range of motion in the wrists and fingers, full range of motion by 3 weeks post-op. Resistive phase begins by week 3 post-op. And then you move into diagonal plane at 4 to 8 weeks post-op. And an open procedure, again, with an open procedure, so surgical procedure, return to play is 3 to 6 months. If they do it arthroscopically, they may be able to get back sooner. It just depends what the damage was. Notice that these timelines are very similar to the shoulder because all of them are based on the healing process. Too, all of these are going to be based on surgical protocols as well. Anytime it's surgical, that doc's going to have a protocol. Little League elbow. Oh my goodness. This is so ironic that I'm talking about this today. My son had a game today, and apparently in the league that he plays in, there is no pitch count, because the coach and I kind of got into it actually on this, because apparently he doesn't give a crap about pitch counts, and oh, he should be good by tomorrow. And I'm one of those, I can tell you the pitch counts right off the bat. I know what they can be and how many days rest they have, because it's just not worth it. It's just not worth it when this is so something we can control. But anyways, it's a chronic condition that occurs only in children. It's on the medial aspect of the elbow due to excessive traction in the medial epicondyle epithelial plate during epithelial plate, yeah, during the cocking phase. It's saying that most commonly involved. What? The medial aspect of the elbow is more commonly involved than any other area. It is thought that curves and breaking pitches taught too soon can increase these stretches, but there's no definitive evidence to support that. But it's just thought that these pitches, place increased stress on the medial epicondyle because they have more of that valgus motion at the arm. But again, it's not been proven. You can have an avulsion of the plate if the repetitive trauma persists, and it can also lead to osteochondritis dissecans. I've actually seen the surgery for the osteochondritis dissecans. Pretty cool. The lateral anterior or posterior elbow can also be affected. It's less common, but that usually occurs due to the stresses during the deceleration phase. Signs and symptoms, you guys know this: pain on the medial elbow, pain within motion, finger and wrist extension, tenderness to palpation on the medial epicondyle, pain and weakness with resisted wrist and finger flexion, swelling, and there might be bruising in more severe cases. Causes are going to be the improper or lack of warm-up, insufficient conditioning, poor mechanics, inadequate rest, pitching too many innings. I even hate to use the word innings, just too many pitches, because there can be some innings you can pitch one inning and you can have 45 pitches. Like that just happened to us this weekend. Stop pitching. They have to stop pitching if the growth plate is damaged. Okay, that's silly to continue to have them pitch. Like, these are young kids that this is happening to. They have the rest of their life. I know it seems like pitching is so important at a young age, but I think at the end of the day, you want to be able to play catch with your kids in the yard more than you want to be able to play, because I guarantee you, people who have trouble at this young age are probably not going to be able to continue to pitch as they get older, because they're going to have too much go wrong if they're not shut down when they need to be shut down. So that passive phase, you're going to have rest, ice, and in advanced cases, immobilization if there's that growth plate damage. Active range of motion as tolerated, again, mainly pain-free. Follows the same progression as adults when it comes to the tendinopathies. It's just not as aggressive. The valgus stress is avoided in the rehab until it doesn't cause pain. So we don't just want to keep adding flame to the fire. There should be a throwing program. They're not just going to bounce right back into this. They should probably be doing the throwers 10. They need to have their mechanics fixed because there's probably something wrong with their mechanics. Okay? You guys should know these if you work with youth athletes. Okay? Even some of your freshmen are going to fall into this 14-year-old range. Okay? So just know that there's a little bit of overlap. Again, for 95 pitches. Again, that should be, oh, this one's weird. Sorry, I'm not as familiar with this one. It's just telling you how many rest days. But I was thinking this one, there had to be, it's down here. I don't know why that one's up there. So, because they basically don't want these young kids throwing in that range. But there it goes. 4 days rest for 75 plus pitches. 4 days rest. So today, all of our kids threw in this range, and he wants to pitch them tomorrow because he's saying there's some research that he found. But, I'm like, you better show me that research quick, fast, and in a hurry. But anyways, you should know this. This is the one I know. Sorry, I don't know what this is up here. But yeah, so anyways, you should know this. You should know the cutoff values. So only 1 to 20 pitches can they throw and then come back the next day. So basically your closers, okay? So become very familiar with these pitch counts. Sprains usually occurs as a hyperextension injury or an MCL sprain, okay? Hyperextension mechanism injury. Pain is in the anterior medial joint line. They may have sustained a bone contusion as well. Bone contusions are super painful. And they may have the pain in the olecranon or olecranon fossa if they have that bone contusion. They may use a support brace in the first couple of weeks to protect the area, and then you're going to move along per usual, pain relief, range of motion, strengthening. Once the injury occurs to the static stabilizers, then obviously we have to rely more on the dynamic stabilizers. But the nice thing about the elbow, though, is that we do have a lot of bony congruency, so that's helpful. The medial flexor pronator muscle is the main dynamic stabilizer. The medial flexor pronator muscle is the main dynamic stabilizer. And in that group, the flexor carpi ulnaris is the greatest contributor from this group. So strengthening of this is deferred until the resistive phase of this. Let me read that again. I just wrote this today. Why does this not make sense in my head? That's the main dynamic stabilizer, the flexor carpi. So we need to make sure we strengthen that, but maybe it's just that it's deferred until the resistive phase. That makes sense, because we want to make sure that we're not strengthening too soon, because then we fall into all those other wonderful things of the elbow. Man, I wish I wrote that better. Maybe it's just, sorry guys, maybe it's just that the strengthening can't happen until the resistive phase, which that makes perfect sense. But I don't know why they're pointing that out. Sorry. I guess read the book, find that out. Cross friction massage can be done later in the rehabilitation. With the UCL is the elbow's primary stabilizer. Injury to the UCL can lead to posterior lateral rotation instability. Surgery is usually needed, also known as Tommy John surgery. I'm sure you're all very familiar with that. They can do a ligament repair, or they can do a tendon graft. They use the palmaris longus tendon when it's done in the tendon's graft. That's the one, like, if you put your hand underneath the desk or you make a fist and like apply pressure to it, it'll pop out of your wrist. But yeah, they use that for a lot of graft anytime they need it in the wrist or the elbow. They have comparable outcomes for the repair as opposed to tendon graft. The elbow is locked at 90 degrees in an adjustable elbow flexion splint, such as this guy right here, for 1 week, for the first week. You guys, it's very similar to the brace that you see in an ACL post-op. You know, it's got the, where you can block it or where you can limit the range of motion. It's got those stoppers in there. You're going to make sure you want to do active wrist and finger exercises, and you can do submax isos, isometrics for the biceps and shoulder, but we're not going to do any lateral rotation because we don't want to provide that stretch to the UCL. And there's no, and they're going to have them do a ball squeeze. So week 1, that brace is going to be unlocked a little bit, or week 2, sorry, the brace is going to be unlocked a little more with active range of motion within that range, and it's adjusted each week to reach full range of motion by 6 weeks. Again, you can do submaximal wrist and elbow isos. After week 3, you can have a gradual progression of the strength exercises. Again, we're going to avoid that valgus stress as much as possible. And you want to add in some shoulder exercises, but we're going to avoid that lateral rotation, that external rotation, because if you think about it, it's going to place more stress on that UCL. They show full range of motion in 6 to 8 weeks post-op. Plyometrics can be added after 9 weeks. Functional exercises are generally added 10 to 14 weeks, and full participation by 22 to 26 weeks. Again, you have to prepare your athletes. That's half a year. Like, that's huge. That's 6 months. I know sometimes 22 weeks doesn't sound so huge, but when you put it in months, it's like, oh my gosh, that's nuts. Please remember, with all these progressions, these are just guidelines and is ultimately based on patient's pain. With the ulnar nerve injury, common causes are incorrect throwing mechanics. So they might have decreased lateral rotation in the cocking phase, so it places increased stress on the medial elbow. The ulnar nerve can be injured by a stretching mechanism. It can be mechanically irritated, or it can actually be subflux. Signs and symptoms are going to have numbness and tingling in that 4th and 5th digit, and they're going to have posterior medial elbow pain. You know, they're probably going to have a positive Tinel sign in that cubital tunnel. There can be operative versus non-operative treatment. Non-operative is you're going to avoid that valgus stress initially, and you're just going to reintroduce it gradually. Operative repair is usually required for subluxing or dislocating ulnar nerve. Basically, they go in there and they put a little, basically they put something to kind of keep it strapped in. Sorry guys, my words are not coming to me today. This is bad. But yeah, they just run a little, what am I trying to think of? I can see it. But basically, if you think of the cubital tunnel, they just kind of run something over the top there to keep that nerve in straight place, because they don't normally do a complete disposition for this, but we have seen one in our clinic, but it wasn't an athlete. Anyways, post-op, they're going to have hand elbow break off to 90 degrees for 2 weeks. The brace DC by week 3. As pain allows, you're going to begin light resistance exercise by week 3, and they should have full range of motion by week 6. Dislocation tend to occur posterior and follow sudden hyperextension and abduction force. They're placed in a posterior mobilizing splint for a few days, and then as needed after that for pain. Some advise no splint due to concerns of loss of motion. So a lot of it's going to be as the patient's able to tolerate, but you want to make sure you see the splint after 2 weeks for sure. They should have full range of motion by week 6 to 8. Joint mobilization by week 8 if it's a capsular pattern. Again, with a dislocation, I wouldn't recommend doing like distraction, because that's going to make the patient super anxious, I would imagine. But remember, you can do the humeral, the ulnar and radial joints, and you can do the humeral radial joints without making them probably quite so nervous. Emphasis on strengthening elbow flexors to provide that dynamic stability, because you have to think if it's a posterior dislocation. With the hyperextension, we might have had some stretching on the anterior aspect of those elbow flexors. They might use a hyperextension brace. Again, I think that's used more generally for patient comfort. By 16 to 26 weeks for return play. Again, that is huge, but you have to understand the extent of the injury and why there's such that wide range there. So if it's an arthroscopic surgery, debridement, the most common ones are debridement of the synovitis and removal of loose bodies. They're usually in the sling for 1 to 2 days. Initially, you're going to use those modalities for pain relief and edema control for all injuries there. And you're going to begin your pain-free active range of motion and passive range of motion. Again, pain-free. Full range of motion by the end of the first week. Again, there's nice recovery following the arthroscopic surgeries. Proprioception exercises can begin after the first week and progress to weight-bearing proprioception exercises tolerated. The resistant phase generally begins around week 3 to 4, and they have complete rehab in 8 to 12 weeks, again, in general. So summary with the elbow. Bony and joint compressive injuries occur laterally, and then we have inflammation and soft tissue irritation from repetitive stretch on the medial aspect. Major concerns with the elbow is loss of range of motion. Okay, again, there's not tons of exercises specific to the elbow, because it's kind of that connector between the shoulder and the hand. We have flexion and extension. We're going to move, when we are doing flexion exercises, we're going to make sure to move from ranges of pronation and supination to bias the different muscles. With extension, we don't have as much to do, except we're going to make sure that we're moving through that extension range. We want to be very cognizant of arranging them, but we're not going to provide aggressive stretches, okay? As always, look at your key concept and review. There's some nice case studies in those books. And fun fact is slugs have 4 noses. It was funny the other day in my clinic, somebody actually asked, they thought they were going to get me. They're like, how many noses does a slug have? I knew that. It's 4. I know. Random useless fact. Anyways, so I have got the PDFs uploaded under the materials. So again, we are not doing the outline for this week. You are going to do those PDFs, and you're going to give me examples of those protocols, of exercises that can go within those protocols. So I have you all doing different ones. I have your names out in parentheses next to the ones I want you to do. Then hopefully I can figure out, if I can't figure it out, Jay will figure it out for me, how to upload all those, so then you guys have some general ideas of what you can do. Feel free to look at protocols online and add those in to your progression, but I would like you to kind of combine a bunch of those protocols, okay? So again, no outlines this week. We are doing the progressions as instead, and you are going to blow in some exercises of what you would do in each phases of those progressions. If you guys have questions about that, just let me know, okay? Hang in there, guys. We're doing great. 4 more chapters and then another class done. Awesome job, guys. Hang in there. You're almost there. Hope you have a super day. Thanks.